Hello, my name is Patrick Osika, and this is my client Liz Maltz. I'm going to do a demo today on how to treat herniated disc. We have, in this case, a double herniated disc, L4 and L5. There's a lateral herniation, and then S1 and L5. There's a ventral herniation. So this is a very complicated case, and I will demonstrate on how to go about approaching that. Also, she had an injury a year ago in which she hurt her neck. So I will also demonstrate an upper body evaluation and treatment at the same time. So Liz has come to us now. This is like her 14th treatment that we've had, and over a 2-month period from when she first had the herniation. The neck injury was a 1.5 years ago, and it never really was properly rehabilitated, so it still gives her pain. And of course, after she had the herniations in the low back, it started acting up again, which is oftentimes the case with spinal injuries. So the first thing I will do is work the upper traps and the splenius capitis and the cervical spine and the shoulder to relieve any tension there before we actually go and treat the side that is getting impinged on the C7 and C6 thoracic outlet and the brachial plexus on actually the left side. So we always want to release the tension on the opposite side first, so that when I get over there, I will have less pressure in my way to work on the site of the inflammation. I'll tell you a little bit about Liz as I work. She is 35 years old. She has had back pain pretty much as far back as she can remember, from when she was 7 years old, and she was rear-ended when they were parked on the side of the road, and she was in a position in which she was turned to the side when the car hit. And ever since then she had back pain and was never properly treated or even diagnosed until recently, when finally, all of a sudden, after cleaning her house one day, the next morning she couldn't move. So we have an MRI, and in the MRI they found 2 herniated discs in the low back. So we know what we're dealing with. In some cases, we have people come in like this, and we do not know what's in there. We do not have the benefit of MRI, but still, we will take an evaluative approach to assess the situation, and that's very important when you have a client like this, that you do not do any kind of therapy that will make it worse, because oftentimes people with herniated disc will have excruciating pain even from just bending down to tie their shoe or even getting in and out of a chair. So normal therapy in many cases cannot be applied. So what we do in Hoshino therapy, we are a specific therapy for treating people in chronic and acute pain. And there is a way to do that which I will demonstrate here today. Now, when Liz first came in, she could hardly move. We barely got her up here on the table, and now after 13 sessions, this is the 14th session, she is now able to be off the painkillers, which she was on for the first 2 months. We took her off of them about 3 weeks ago, and now she's been stable without any anti-inflammatories or without any painkillers, but she still is in a lot of pain and will need still further rehabilitation. What I'm doing now is I'm going through all the muscle groups in the upper body, releasing any tension or adhesions that I might find there along the way with our 270-point evaluative therapy and diagnosis. What I'm doing here is I'm looking for any pressure points which are particularly sensitive, which will tell me about where I need to work in order to relieve the pressure on the cervical spine. A lot of people fail to recognize how important that is to work not only on the site of the injury, but even more importantly, around it, on the muscles and the joints surrounding it, because it is there where the dysfunction starts to spread. And oftentimes the site of inflammation, you can only work on it so much. So the dosage is very important. If you overstimulate an inflamed nerve, you will surely make it worse. So oftentimes when you have inflammation on a nerve or a disc, the actual proper method of treatment is not to treat that area at all, but treat distally until the inflammation is relieved, and then you can work on it safely without any risk or harm. So I'll do a basic assessment of the glenohumeral joint and see how it's functioning. And this one has all the movement in it that we would expect. So now I'll move to the other side. And I don't know if you can see on the camera here, but from my vantage point, I can see that this shoulder is a good inch higher pronated forward than the left. Now she has the same tendency on the left side, although not as sharp. So one of our goals posturally here to correct this, which is not all due to the injury, some of this was here congenitally. This is her body and her seated posture of her upper body, which is part of the reason why she's vulnerable to injury here, aside from the fact that a coat rack fell on her shoulder. But I don't only want to treat the injury, but I also want to treat the posture in order to get a truly better result. Not only to treat the injury, but also the underlying conditions which create the injury, like the pronated shoulders, which eventually down the line will make her stronger and healthier in the upper body and prevent this kind of injury from happening again. So on this side we see there's a lot more inflammation. I can tell this by not only her pain level, but the thickness and the elasticity in the tissue, and also the sensitivity of the pressure points. We here find that on C1 and C2, slightly subluxation to the left, and around the scalenes, there is a lot of tension where they have become adhered to the transverse processes. So I will gently relieve them, careful not to overstimulate that area because it's close to the nerve and the nerve is still slightly inflamed, I can tell by how sensitive she is to the pressure there. One of my objectives here is to release the pec minor and also the levator scapula, which are in spasm still, and I know that from the last treatment when I worked on her. Although now they have improved by at least 40%, but still they are contracted and in spasm. So, and actually,
generation, there can't be only 4 people in this country doing it. It's ridiculous.
Okay, all right.
okay, so now I will work on the upper traps and the levator scapula and the splenius capitis and anterior scalenes, which are very important for releasing the lateral aspect of the transverse processes of C1, 2, 3, and 4. One has to be very careful working around these areas that they do not overstimulate, because you can very easily bruise an inflamed or entrapped nerve. So sensitivity is the key into dosage, so you know how far you can push the point without overstimulating it. Right here, between C2 and C3, I find the inflamed nerve, which Liz can tell you is very painful, even though I'm applying less than a pound of pressure. So it's very important, areas like that, not to overstimulate them. Just a little bit of stimulation is all that's necessary. And then you'll go distally from the area to relieve the pressure from the thoracic outlet, which here again is in spasm. And I can tell by the reaction of the muscle tissue under my hand and how it jumps back when I push on it. So I never want to force. I want to use just as much pressure as the muscle and the nerve can tolerate at this time until the inflammation goes down, and then I'll be able to work on the area with deep pressure safely without risking injuring the nerve. Now, because this injury has been here now for 1.5 years, it has had time to create lots of adhesions between the muscle fibers and the tendons. So this then, over time, becomes more of a problem than the original injury, and also prevents the nerve from recovering, because these muscles, like the pec major and minor, which have gone into spasm around the thoracic outlet, now create constant pressure, re-injuring the neck. Now I will work on the lats and the teres major and minor. I make sure that I put the arm in a position that allows me to do this, and also that is anatomically correct, lining up with her spine, so that when I do work on the muscle that I am targeting, I am also aware of the proper alignment and posture of that joint. I don't want to just allow it to work in a bad position. I want to actually put it in a correct position, and then there, in that position, in that anatomically correct position, is where I will try to release it. It's little details like that that make the difference in your results as a therapist. Now we will treat the anterior deltoid and the long head of the bicep. In Hoshino therapy, we have a special hand technique for the safety of the therapist's hands and also for the comfort of the client. We never approach with pointy fingers or pointy thumb. We always use a whole hand, and then we apply the pressure. This makes it a lot more comfortable for the patient when you have to work on areas that are very sensitive and inflamed. Also, I cover more surface area, I compress more muscle tissue and lymphatic and circulation, as well as I warm up the area with the heat from my hands. There's a lot more heat if I have my whole hand applied than if I just have a couple thumbs and fingers. Moving on to the brachialis, which all these muscles I find have lots of adhesions. And I'm comparing it with what I found on the right side and using the right side as my guide as to where this stuff should be and the proper tension and balance between both shoulders and the neck and the pectoral girdle. I look for balance and symmetry and muscle tone. I want to see as even a balance and symmetry and muscle tone and spinal alignment from left to right as I can maintain. Now here is a very important area for the insertion of the triceps, short head and long head, and the middle head. These attach on the back of the scapula and work with the levator scapula and control the position and angle of that upper back part of the neck. So if I find a tricep in spasm, I know that I have to release this in order to get a very good result up here. So we are actually working on the neck by working on the tricep. So a lot can be done even if a person has an acute whiplash or a herniation in their neck. You never actually have to touch it to treat it. And that is one of the keys to our therapy with working with acute injuries. Which the most important thing is not to make it worse, not to aggravate the injury, and yet relieve the pressure on the spine so that the person can recover quicker. Now moving on to the flexors of the forearm. And here I find that same tension that is coming through the thoracic outlet and the cervical spine, because as those nerves get compressed, it causes an involuntary muscle contraction throughout the whole thoracic outlet, which then travels down all the way into the hand and even the fingers. So when you find these reflex points in the hand, you can actually relieve different points on the neck by working as far down as the hand and forearm. Here I find part of that entrapped nerve in C2 and C3. I know this from experience. And the pressure here, on a scale of 1 to 10, if I had an average arm here, I would expect to find a pressure of 3 or 4, or even 5 would be normal. Hers right here is up on 8 and 9. So I want to always check these points and make sure that I see a reduction in the pressure and the sensitivity. And that will then let me know that my work has been successful. If I do not see these changes in the pressure points, then I know that my evaluation has to be reassessed and my approach has to be reevaluated so that I start to make progress. This is our focus as a therapist and a result-orientated therapy. If we do not get results, then we are not accomplishing our goal. So we want to always see progress, and that lets us know that we are doing the right thing for the problem. We do not want to rely just on our intuition or our past experiences, because each person can be uniquely different, even though they have the same injury. So now we will move on to the lower body treatment and evaluation. First thing I want to do to make sure that the patient is safe to work on without injuring her is I will do a gentle range of motion test to see how sensitive the nerve and the joint is. So here I'm checking the hip flexors and lateral rotators. I find there a little bit of resistance and a nerve compression from the piriformis and sciatic to the inside. I am being very careful not to force the stretch, but just see where the joint moves naturally and where its end feel is. The end feel is where the tendon reaches its maximum stretch and then refuses to go any further. So we see here we have the hamstring is in spasm right now, as well as the piriformis around the sciatic is a little entrapped. Also, we have from the adductor magnus a limitation there. So I will gently check the hamstring. Okay, definitely sensitive, but not so inflamed or sensitive that it's unsafe to work on. So I will now proceed to work on the iliotibial band first and vastus lateralis in order to relieve the tension from this main tendon, which is very dominant, especially because on the L4, L5 herniation, the hernia protruded to the left side, compressing the transverse nerve as it's coming out down the outside of the leg and sciatic. So I've been monitoring this on her and making sure that every time when I come in here, I check this tendon, and this tendon is my main gauge in her progress. Today, I feel it's much stronger, as well as a little less tight than it's been the last 13 sessions. So I know that is making progress. Again, when I'm working, I want to make sure I position the leg in a nice aligned with the hip and with the foot before I work on it, so that I have a positive anatomical stimulation on that leg. I don't want it to be in any other position when I'm working on it than the position that I see is best aligned with the joints. Now I will move on to the peroneus, which is very interesting for her. When she first came in, this was one of the most sensitive points besides the pain in her back. And as you can still see, it's very sensitive there because it went into spasm when the L4 herniated. This is another one of my indicators on her progress, is this pressure point right there on the peroneal and on the tibial anterior right there. Now, she had a secondary injury due to all the stress from the herniation, and when she was stretching, which was not advised, but she felt like stretching, and she actually popped a part of the hamstring, the lateral head of the bicep femoris. It wasn't a complete tear, but just a partial tear, and that often happens when you're dealing with herniated discs, is that after the disc is herniated, there's all kinds of secondary injuries coming because the spine is unstable, and when people are walking around and going about their daily activities, they often have other injuries that result. So she actually ended up tearing a little bit of that hamstring, and then afterwards her symptoms got worse again. She had a relapse and was left with numbness along the peroneal nerve here, which she has lost a little bit of sensitivity here. Now, I'm very pleased because as we've been working, that numbness has gone away, and slowly the feeling is coming back. Originally when it happened, her toes actually went completely numb, but now she is starting to regain feeling in there, so I am not so worried about that anymore. Now, those kind of symptoms, when you see them, those are big red flashing lights. You gotta be aware of that and make sure that the person recovers or gets proper help, because there might be spinal impingement, which we know that there was. Now, Liz is a candidate for open back surgery. That's what the neurosurgeons recommended, but she made the choice that she wanted to try natural medicine first and exhaust that before she went to surgery. And so we are here working on it, and so far so good, because she is making very good progress for this kind of an injury. So now I will move on to work on the Achilles. Again, I make sure that I have the body in a nice, aligned, anatomically correct position before I start working on it. Achilles is very sensitive today and has been. Part of the treatment for Liz that we are doing, aside from the acupressure, is I have her wearing ACE bandages in order to stabilize the ankle, which has become very unstable since the back injury. And I also had to change her shoes, because the shoes she was wearing, not only were they not good shoes, but they weren't offering the support that she needed. Now, when people have a low back injury, the foot becomes very important for their recovery. If they have instability or any kind of congenital deformation in the foot, like Liz does, a flat foot, as you can see here, we know that this is a disposition for back pain, and definitely was a part, besides of the injury to the spine itself, congenitally she was disposed to have these problems because of her flat feet. So part of the treatment for her is not only getting her through this acute phase of the injury and letting the herniations to heal up, but also to change the arch of the foot so that she will have a stronger foot, and which will make her whole body stronger and her back stronger and prevent these kind of injuries from happening again. Now, in order to do this, we have correctors. These are very special correctors. These are metal, which is the only material which is really strong enough to significantly change the foot. They are custom made, and they'll be worn in her shoes as a therapy. Even though she is 35, it is still not too late to correct these problems in the foot, and that will give her overall a better result. Now, in order for the correctors to be effective, we have to have a proper shoe to wear them in. These, although not very stylish, are very good to offer the support. I like how they have the heel and a whole round toe, and that they lace up tightly around to almost even splint the leg and act as a splint, because her lower leg had become very unstable, especially after the spinal injury, when actually I noticed in the first 6 sessions that her arch, aside from the numbness that started to happen, crippling her toes and her foot, also her arch started to collapse. So it was very important to stop that from happening, because oftentimes what happens in this kind of case is the person's spine gets injured and the low back gets injured, but then degeneration and other kinds of arthrosis, which is a hardening of the tissues, happen as a result of the nerve being compressed. So I want to maintain the health of the lower body and the function of the lower body through the process of healing. Because oftentimes people will heal from herniated discs, but then afterwards they're left with collapsed arches, or contracted Achilles tendons, or shin splints, or plantar fasciitis, and other kinds of joint injury that then becomes more of a problem in the future than the back injury itself, and then leads to further back injury. So we are taking this into consideration as we are treating her, not just for temporarily relief of the pain and the symptoms, but also to make sure that in the future she continues to rehabilitate and get better in order to prevent further injury to those now weakened areas in the spine. And also we are going back in time and correcting things that actually should have been corrected long ago. So now I am working on the vastus medialis, adductor magnus, and the sartorius and gracilis, and semimembranosus and tendinosus of the hamstring group. We do this all from the inner leg here. Again, a very sensitive area, and one has to be very cautious to apply a tolerable amount of pressure so that you can get a good stimulation without irritating the client too much, so that they don't contract. I do not want my patients, even though I'm working on very sensitive areas, I do not want them to contract in response to the pressure that I'm applying. So I go to the point where I start to feel the contraction, and then I back off. Now I work the Achilles tendon and the soleus from the inside leg. Here is an area where sciatic nerve impingement always wants to collect its pressure, and it's very important for the low back to relieve it from this part of the foot. Also, the sensitivity here tells you about the progress that the nerve is making and the inflammation in the low back. So now I will move on to the plantar tendon of the foot, which again, before I work on it, I make sure I properly line up the metatarsals with the knee in its best possible anatomical position that I can obtain. And then I work on it, relieving it in that position. Now, with the correctors and the proper shoes, which I will have her wear for the next year, and then continue to wear even for years afterwards, we'll begin to correct the posture of the foot, making her actually even better than before the injury in many cases. In Liz's case, on top of having several accidents which damaged the spine, her foot posture was also responsible for just daily stress and wear and tear on her low back. So it should not be overlooked, even though it wasn't directly responsible for the herniation. So now I will again check the range of motion after I've worked on it to see the response. And definitely I get a couple more inches and a lot less resistance in the movement. Now this leg was the most severely affected from the injury that happened 2 months ago. And so this is the one where I've been closely monitoring for improvement. Okay, so now I will evaluate the right leg, which in Hoshino therapy, when we approach an injury to the low back, we are not going to can I start that over again? Okay. Okay. So now we will evaluate the right hip flexors and lateral rotators, and the hamstring and the adductors. This leg was always more flexible and stronger and in better shape than the left. And so I'm going to use this as a basis for the changes that I want to see in the left leg, because I want them to be as symmetrical as possible. This is the problem with gait and low back injuries in its chronic form and its postural form, because a lot of people get into poor postural habits and they actually are walking unevenly. They use one leg differently than the other. This eventually causes the spine and the pelvis to rotate, then causing nerve impingement and ultimately bulging of discs and subluxation, and down the line herniation from wear and tear. So in order to correct that, we want to find and create as much symmetry and balance and muscle tone and a joint alignment of the spine and of the leg, from the toes all the way up to the low back and even mid-thoracic. So in Hoshino therapy, we do not focus on the site of injury solely. We are looking for balance and symmetry between both sides. So we always treat both sides of the body, even if the pain is only on one side. You will often find sometimes trigger points on the opposite side of the leg that's injured or the arm that's injured that are more severe than on the side that's injured. This is a compensation of the nervous system and of the muscular system in order to guard and also protect the injured area. This is a double-edged sword, because in the long run, if it's not corrected, it prevents the person from fully rehabilitating, and also leads to other injuries, secondary and even tertiary injuries, that are coming because once the body's injured, it goes into spasm and people start compensating and they create other problems in other areas. And that's what we want to avoid in this time when we're treating her, that we isolate the areas that are injured and protect the areas that aren't injured in order to get the best result possible. Because what happens when that nerve gets inflamed, it causes the entire lower body to go in spasm, especially when it's on L4 and L5 on the main sciatic branch. Then the inflammation just spreads through the nerve to all the muscles of the body, causing them to contract. That contraction then is what impedes the body from healing, because it puts more pressure on the low back and the spine, and it never gets a chance to get rest and recover. Even when the person is sleeping, the muscles are busy working and contracting, and the person slowly gets worse and burns out. So it's very important that people recognize that when they're working on this, is that it's not just the L4 and 5 injury that we are looking after. We are looking after the entire body and all the side effects that happen along with that injury. Okay, now in the beginning we had to be very careful when we moved Liz, because she couldn't roll over to the side and hardly could get up and sit up. Now that's not a problem anymore, but I will demonstrate anyway the proper way to move a client when they have injury to the low back. So first thing we will do is we will raise their knees. So then I will have my bolsters ready. And what I will have Liz do is first I will have her breathe in, deep breath, and then breathe out, and I will have her contract all the muscles of her abdomen, making it really firm around the low back. And now when you're ready, we will move her all at once, shoulder and hip, over on the side. You ready, Liz? Okay. And she'll tighten her stomach and roll over at one time. There. Then very carefully, I will have her move over. This way, there is no twisting and turning, which when there's a herniated disc is very dangerous action to do. That's when the nerves can be impinged and damaged. So now this is our position in which we will then work on the glutes, the tensor, the quadratus lumborum, and the piriformis, and the other 5 lateral rotators, which are very important for relieving the sciatic nerve and sacral compression. And I always will go here and check my S1 sacroiliac joint, because this is what I've been monitoring for the herniation down there. I've been checking the pressure and the tension in that area and the sensitivity in that area, which then tells me if I'm making progress or not. Because at this phase of an acute herniation in the low back, progress can be very deceptive, because the person's in so much pain that oftentimes they cannot tell. So we always are looking at the body as a whole, even though we are focusing on L4, L5 herniation, and L5 and S1. That is our focus, but in order to get there, we are going to treat the whole body. And any improvement that we make is going to minimize the pressure and the stress on our body, giving her a better healing and a better result in the long run. So we always work evenly both sides of the body, and then we will focus on the area which is affected. And I also need to work on the opposite side for reference to what's happening on the left, in order for me to figure out the best way to balance her. We are finding on this side, although it is not as tight as on the left, in the same areas affected, she also has the very strong trigger points on the peroneus and on the tibialis. So I want to make sure I relieve those two on the right side. Also, this being her good leg now, she has come to rely on it much more when she's walking because she's limping right now. So in order to get her through this, I want to make sure that the right leg stays in good shape and good condition because she's going to be overusing it during this period of time. Now, I know from experience in working with many lower back herniations that we have a timeline here that we can expect. In the best cases, manually treating these conditions, we can expect there are at least 6 months of therapy, if not 9 months, before she will be ready for a normal rehabilitation with a physical therapist and going to the gym and yoga and other kinds of working out. At this stage, though, it's very important that she doesn't stretch or do any weights or any aggressive impact therapy. I have her now mostly exercising in the water or doing stretching very gently on her back in a safe position, not weight bearing where she can possibly do any damage to the low back. We put her in the water, which I like her to be in the water, just floating on her back every day for a half an hour to 1 hour, once or twice a day. This is because the water is the only place where we can get away from the gravity. And when a disc is herniated and the annulus bursts and spills out into the spinal cord, which is what it has done, into the foramen of the spine, until the body absorbs that and the swelling goes down, the spine is going to be very unstable. And the water is the safest environment because it takes the gravity off of the disc and also allows the disc to actually expand and allows it to heal best. So for the first couple months, when I have a client like this with a severe spinal injury, I do not want them doing any weight-bearing activity. The weight-bearing of just getting in and out of bed and standing around and sitting is oftentimes more than they can handle. So we certainly don't want them to do anything else until finally the herniation has healed and the pressure on the spinal cord has been relieved. Then once I feel that that has happened and I see the signs that she has recovered and that the disc has scarred up and healed, then we are ready to start doing the next phase of rehabilitation, which will be much more aggressive stretching and weight-bearing activity and strengthening. But until I find the low back is stable, we do not want to do that because we can actually cause serious damage to the spine and the nervous system when the spine is floating like that. Also, heat and ice have been very important for her, even more important than the anti-inflammatories, because the regular application of ice to the L4 and L5, bringing down the swelling on the nerve, and then the heat, actually not for L4 and L5, but for the muscle and tendon, in order to heat it up and soften it and improve circulation. Okay, so once again, before I start working, I want to make sure that I have the hip and the spine in a nice aligned as possible right now, because she's in spasm, but I want to put it in the best possible position before I start working on it. I do not want her sloppily lying over to one side or the other. I want to have a nice, even and as relaxed and comfortable position as possible, but also anatomically correct. So now, this area in a herniation is often very sensitive and inflamed. So it's very important to be careful with the doses and the pressure, because overstimulation of the sciatic nerve in this kind of situation can oftentimes make the person much worse. Although the stimulation is necessary in order to relieve the nerve, overstimulation is contraindicated. So I'm here checking and also taking notes for when I work on the left side. This is my reference and comparison, and that's how I know what needs to be balanced and where I want to go, what my goals are with this lower body. I have to mirror image the left and the right side. Oftentimes there will be a rotation in the pelvis, and in order to unrotate the left side, the right side will need to be often equally and oppositely adjusted, because it works just like a pendulum. When one side goes up, the other side goes down, and vice versa. Only it's much more complicated, because the way the pelvis works, it's moving actually in 8 different directions. It goes up, down, side to side, forward and back, pelvic tilt, and also the SI joints have to be checked, that they have also enough give in them. Even though it's a fixed joint, there is a certain amount of mobility that is necessary in them for the sacral nerves to be free. And so that is what I am looking for and checking now, and relieving any tension that I find on the femoral joint. First, I warm up the gluteus maximus so that I do not have that resistance in my way when I start to go in deep on the piriformis and the gluteus medius. Right now, I will go in on the piriformis very slowly at first to warm it up and get it ready for pressure. And then now when I feel that it gives away a little bit and lets me in, I start to go a little bit deeper. This side, I'm noticing today, has made much improvement since the last treatment 3 days ago. And here actually I'm finding today more pressure on the last quadratus femoris, the last lateral rotator. And this is an excellent position to work on these little guys, often neglected by lots of therapies, and they're very important for controlling and adjusting the angle that the femur articulates in the acetabulum. Those are the little guys that control the rotation of it. So if they are obstructed, there will be lots of dysfunction in the hip. I'm always careful not to go in pointy with the thumb, but always apply a whole pressure with my hand. Even though my focus will be on one point with the thumb, my pressure is buffered by my whole hand. So I actually am working the whole glute while I'm targeting one pressure point at a time. Now I'll work on the tensor. Another very important muscle that controls the iliotibial band, this large tendon here, and it's very important if it's jammed to release that. Today she is very tight on the tensor. And now that I have prepared that, I will then go to the more sensitive area to work, the quadratus lumborum.
Okay, please start anytime you're ready.
Can you airbrush any pimples?
Yeah, they'll laser everything out later. Okay. Are we ready? Okay. So now, in this area, we have the herniated disc. So this is actually, at this point, which is still the acute phase, and there's lots of inflammation and nerve compression here, I do not want to overstimulate this or even work on this too much. I have been until now working mostly on the lower body, stabilizing and releasing any nerve compression and adhesions there, preparing the back for the deep tissue work, which is now finally being able to do. In the beginning, this area was so inflamed, it was actually red and raised, and you could see it, and it would have been a big mistake to actually work on it. That is oftentimes why, when people have these injuries, massage is not successful, because the people work on the actual injury. And it's very important that when you have an inflamed nerve, that if you touch it very gingerly and with very little dosage in the beginning, if you even touch it at all. So now I know that it's ready because I've been monitoring the progress with the inflammation here, and now I actually have a very safe low back to work on. So I will start very gently to just relieve the erector spina muscles of the low back and the quadratus femoris. Once again, being very careful to have the body of the spine in a proper position and alignment before I work on it. And I'm using very little pressure and always with my full hand contact. It's more comfortable that way, and actually when the muscle feels safe and supported, it allows me to use deeper pressure with better results. So what I'm doing here is I'm gently releasing the quadratus femoris and rolling it away from the spine, making sure not to twist and rotate and turn the body while I do it. I want it to stay nice and still. So here I apply a gentle traction, because if you can see, the hip wants to rise and compress on the transverse process. So I will gently unrotate them and then go in onto the transverse process and gently release the pressure there. Careful not to overstimulate, because this is where we have the herniation and we do not want to move it too much. Still at this point, it will be at least 3 to 4 months before those herniations start to scar over and heal up. So until then, I do not want to move these too aggressively or stimulate them too much until I know that they are stable. Okay, good. Actually, much better than last time. Now I will work on the tensor again. Again, being very careful to create a proper posture between the low back and the pelvis before I start to release this tensor. Which is a very sensitive muscle to work on even in a healthy person. But when a person has a herniated disc, it can become very sensitive and inflamed. But it's a very important muscle to release for a low back injury, oftentimes neglected in many treatments. Left side of the hip and low back.
Starting.
So now we will observe the left side of the hip and low back and note any kind of changes and difference from the right side. I see here that there's a little bit of a crease here. This is because that side of the hip wants to collapse and it is rising up. I want to eventually see this happen to this part of the spine. I want to see the proper lordotic curve come back, and any kind of irregular muscle tone to come to a more anatomically correct position. So right now it wants to do this. And that is where the worst part of the herniation is. It collapsed on the left side, causing these deformations in the muscle and in the angle and posture of the pelvis. So when I want to treat her, I want to make sure that I unrotate that before I work and get her body in the best anatomical position before I start to stimulate it. So now again, I will very carefully first gently warming up the area and introducing myself before I start to go in and work on it. Now this side has always been more sensitive, and it is today as well. So I'm always more careful on this side where the inflammation and the spasms have been very strong for the last 60 days. Although today we are seeing definitely much improvement, which is a good sign. I've been using steadily more and more pressure as her pain threshold has gone up, which also tells me that we are heading in the right direction. So here on this side, I am finding today a lot of pressure on the gluteus medius. So I will start to work there. And when you have these kind of spine injuries, as the nerve goes through its stages of inflammation and the muscle goes through its stages of contraction, oftentimes you'll have a different situation from day to day. So it's very important that you are responsive and lucid enough to change your approach as the body is changing through its healing process. You cannot get too sloppy and lazy and just get into a pattern. You have to be responsive and change your therapy along with the body that's changing day to day. So on different days when she has relapses or sometimes other kinds of injuries and the inflammation swells up, I have to change my treatment. Even though I might have been able to work on her one way the day or week before, if she has a relapse, I have to again change the way I approach the injury. And with these kind of injuries, you will see all kinds of things happen from day to day, because the back is unstable, and so one day a hamstring will go into spasm, the next day a foot will go into spasm, the next day the low back will go into spasm, and each time you have to handle the situation differently in order to get the best result. Now here we find today on the S1, L5, sacroiliac joint, very tender today. And I will have her, when she goes home after this treatment, to actually ice that there, as it needs a little bit of ice for the inflammation today. But I'm pleased to find that the muscle tone in this hip is finally coming back, and I'm feeling a much stronger glute and a much more tolerant piriformis, which before was very weak and inflamed. Now I'm actually getting some muscle tone in it, and I'm happy about that. Now that I have prepared that area, I will go on this side, which has been the most affected and the most inflamed. I'm going to be especially careful working on the quadratus lumborum and erector spinae. And now I am seeing here today that although the inflammation has gone down greatly from how it was last week, the muscle tone is very flaccid. So I know that it's weak, and I do not want to overstimulate it. Just want to give a gentle little release, making sure that when I work on the spine that I do not move it too much. That way I don't risk compressing the nerve in there, which has no disc right now to support it. So I have to be very careful in this area. One wrong move can basically set the person back weeks if I do bruise that nerve, which is very vulnerable.